everybody. It's lovely to be here this morning and to talk to you. I will tell you a little bit about me so you know why I'm here, what my background is. So I'm a specialist speech and language therapist. I work on the same department, same hospital site as Professor Banker. But whilst he is up with, whilst he is, whilst he is somewhere in the echelons of the upper regions of the hospital, I'm right down on the ground floor in the cleft unit, so just down the road here in Manchester. I trained in Manchester in the late 80s and I took my final exams in this building. So I don't have the best memories, but I did do okay. I'm going to focus on speech. So working with children with cleft lip and palate, speech is my focus. But we have to remember that speech is just one part of communication. So children have to be able to have all these foundation skills before they can develop good speech. So it might be that you've had to work with your children, or you're working with your children now on developing their attention and listening skills, their play skills, and you wouldn't believe how much those skills are important when it comes to learning to speak later on. So that's what I'm going to focus on today. So what is speech? So there are different aspects to speech. There's how we make speech sounds. We refer to that as articulation. There's our voice, so our voice quality, how our vocal cords work together and how our voice sounds. There's fluency, so that's stammering, and there's also resonance. So that's to do with the tone of speech, whether it sounds nasal or oral. The ones I'm going to focus on today are the ones that are more involved with the way that the palate works. So that's articulation and resonance. But a child might have problems with all of these. I worked with a little girl this week who has a bilateral cleft lip and palate. I'm very sad that I wasn't able to do the assessment because she's so disfluent. So the priority for that child is to be seen by her local speech therapist to help manage the stammering before I can then focus again on the speech. So these aren't mutually exclusive, and we have to work on whatever is the priority at the time. So I'm not going to talk about language. I'm not a language expert, but speech and language go hand in hand, and very often a child will have speech and language difficulties, and it might be that the language problems are being met or dealt with in the classroom, whereas their speech difficulties might be being dealt with by a speech therapist or with sessions with a speech therapy assistant, that kind of thing. So I'm not going to talk about language, but it is equally important as speech, just not my bag. Okay, so just to really reiterate that speech is just one part of communication and that children can have difficulties in other areas, including social skills. So more and more children are getting diagnosed with autistic spectrum disorder and needing help with that social side of communication. So we just need to bear that in mind. Okay, so you're not ready for that? We are now. So I'm no expert in Kabuki syndrome, although I have worked with some children with the condition. And from working with them and from the literature, comprehension or understanding of language seems to be a strength. So that, not for all children, but for the majority of the ones I've worked with and in the literature. Expressive language or talking can be slower to develop. So they do tend to be later with first words. At 2 or 2.5 years. And I think it's good to be mindful of that and not panic, because you can still be working on the attention and listening and the play skills, and those are the foundations for speech and language later on. And I think sometimes parents are like, oh, why are we working on attention and listening? We want to get to the talking, we want to get to the language. But if you remember that you need those foundation skills on which to build the speech and language development, it kind of all makes sense. And also from the literature, children with Kabuki syndrome later on can have problems with semantics, so word meanings and sentence structures. So they might need specific help for that as their speech and language develops. Speech problems, so speech sound development can be delayed, so a bit like the language can be later starting. Children might not say their first words till they're 2.5. So the speech sounds might come a bit later. So this is just a developmental delay that might tie in with their delay in other areas of their development. So for example, when other children in the class are able to say sounds like K and T, a child with Kabuki might be a bit later in those sounds maturing. So they might be saying video for video when other children have learned to do that a little bit earlier. It doesn't mean to say they're not going to get there, it just means that they're likely to be a bit later with it. And then as they get older and their speech and language problems improve, they may still be left with problems managing loudness, intonation, and controlling the pitch of their speech. Now, the main thing I'm interested in is resonance. So this is really important when it comes to cleft palate, is the tone or the resonance of somebody's speech. And resonance can be different for a child with Kabuki syndrome if they've been born with a cleft palate, found to have a submucous cleft palate, or have this condition called non-cleft velopharyngeal incompetence. So it sounds like a big mouthful, but I will demystify that as we go along. And I think the main thing to say when a child is identified as having a communication problem is they need really careful assessment by a specialist speech and language therapist or by a community speech and language therapist. But it needs to be a detailed assessment to work out where are the main problems, how are these best addressed. And the other thing to say is that a problem with the palate doesn't stop a child from talking. It's probably a general developmental delay that's stopping the child get going. A cleft palate means speech sounds nasal and is unclear rather than a lack of language. So who is best to help? If a child has a straightforward speech and language delay, a community speech and language therapist, nursery practitioner, teacher, teaching assistant and parents all putting together are the best professionals to help the child. If they have a problem with their resonance and articulation, specifically around a cleft palate or velopharyngeal incompetence, then they need to be under the care of a specialist cleft team, including a specialist speech therapist like myself, and all of the above. So, how can the resonance of someone's speech be affected? It's usually typically a cleft palate, which is something that you're born with, and you can see here that there is a big U-shaped cleft. So this usually occurs around 8 to 9 weeks into embryonic development, when the two sides of the palate, we call them the palatal shells, don't fuse. So these should fuse pretty early on in embryonic development. For some reason they don't, and the child is born with a cleft palate. There is another condition, a submucous cleft palate. This can also be part of the condition for children with Kabuki syndrome. Submucous cleft palate isn't picked up at birth. It's usually picked up, I think, on average around 3.5 years of age, and it's usually identified when a child has nasal speech symptoms. So it might be that some of the clinical features are noted on an intraoral examination before that, but usually they don't present to us until they've actually got nasal speech symptoms. And one of the main indicators that people notice is a bifid uvula. So that's when you should have one dangly thing, like a punch bag at the back of your throat. If it splits, that's called a bifid uvula. Now, you can, in the normal population, it's 2% of the normal population can have a bifid uvula with no other health issues. So I've got a friend who's a speech therapist in Manchester. Her husband's an architect in town. He has got the most bifid uvula I have ever seen, but doesn't have any speech problems or any other health issues. He does move, sometimes bread catches up round there, but it's big boy pants on, that's nothing to worry about. So just a bifid uvula on its own isn't to worry, but if you've got other features, such as a bluey grey midline, which is where there's a lack of muscle in the middle of the palate, or a hard palate notch on palpation, it might be that you have a submucous cleft palate. The thing is about submucous cleft palates is we don't repair them all. So all cleft palates are surgically repaired. It's about 85-86% of submucous cleft palates get repaired. Because if the child is developing normal speech, we're not going to go in and interfere with that. But if the submucous cleft palate is giving rise to speech problems, then it is repaired. Okay, then there's this other condition, non-cleft velopharyngeal incompetence. It doesn't roll off the tongue. So I need to explain what these terms mean. So velum is the Latin for soft palate, pharynx is the throat. So this velopharyngeal sphincter is made up of the soft palate in the back of the throat. And I was teaching some university students the other day. I kind of said my whole career is around this sphincter. How this sphincter works or doesn't work, really, honestly, is what my whole life revolves around. So this sphincter, which is at the back of your nose and throat, you can't see it when you look in your mouth because it's too high up behind your nose. This has to open and close properly for the resonance of your speech to sound typical, and also for you to be able to speak make some certain sounds of English. So if you've got a cleft palate, or a submucous cleft palate, or non-cleft BPI, this doesn't work properly. So we call it velopharyngeal incompetence, because that velopharyngeal sphincter doesn't work. And the symptoms that you get from this are the same as if you've got a cleft palate or a submucous cleft palate. So it's all about this sphincter opening and closing properly. So how can problems be affected by poor velopharyngeal function? Speech sounds hypernasal. So that's when you have too much air resonating in your nose when you're talking. Yep, so I've got air flooding into my nose when I'm talking. You also get extra puffs of air, which I'll demonstrate in a minute while you're talking, because you've got air leaking down your nose because that sphincter isn't closing properly. And then you also have a difficulty making the oral pressure sounds of English. Sounds like p and p, p and b and t and d, because you need to build up intraoral pressure to be able to release air from your mouth in an explosive way to make those sounds. And if the sphincter at the back of your nose and throat isn't closing properly, air leaks down your nose and you can't build up that pressure in your mouth. So you go to say baby and it comes out more of a me with air leaking down your nose. So this velopharyngeal sphincter, of which the soft palate is a part, it's really, really important for speech, but you don't know you've got it, you can't see it, you can't feel it, you can't control it consciously. The other side effects of having problems with your velopharyngeal function is your voice may be hoarse, and also children, very often you'll see them grimace their nose because they have a leak of air. The body tries to do everything it can to stop that leak, and so they grimace their nose. So I've demonstrated hypernasality. So this is one of the speech features of the velopharyngeal incompetence. It's when there's too much air down the nose. It's in fact the opposite of hyponasality. So when you've got a cold, you haven't got enough air in your nose. So this isn't anything to do with the way your palate works. This is if you've got a cold or you've got enlarged adenoids. So we wouldn't really worry about this, but we would be more worried if a child presented with hypernasal amendments. Other features as a result of velopharyngeal incompetence and cleft palate is the nasal emission and nasal turbulence, and that's where you hear extra puffs of air down the nose. So if I was saying the word puppy, it would sound like something. Can you hear that? Again, you've got air leaking down the nose when you don't need it. Nasal turbulence is noisy. It's like, yep, you hear that on top of speech sounds. Again, all to do with leak of air through this velopharyngeal sphincter into the nose. Good. How do we assess these abnormal speech presentations? We do an auditory perceptual speech assessment. In the UK, we use a nationally agreed assessment tool. It was designed in the 90s and it's called the Great Ormond Street Speech Assessment. And we grade how hypernasal speech is, whether we hear any of that nasal emission or nasal turbulence. So here is the sphincter, which my whole 30-year career has been dedicated. So you need to think in 3D. This is the soft palate down here. This is the back of the pharynx, or the back wall of the throat, and the side walls of your throat. And as long as this closes, can open and close satisfactorily, that's great. If it doesn't, we've got a problem. And even in individual normal speakers, we found that the pattern of closure was different. For some people, the soft palate moves more. For some people, the lateral pharyngeal walls move more. It doesn't matter as long as it closes. And this is a side view of the same said sphincter I dream about at night. So this is the soft palate just dangling down at rest when you're breathing. So air comes up from the lungs and you breathe in and out of your nose. But you don't want to speak down your nose. So the soft palate has to lift up to form this velopharyngeal, to close this velopharyngeal sphincter here. So the air comes up from your lungs, it's directed out your mouth, and you can say strong p and b and t and d, for example. So how do we investigate what's going on? How does the surgeon plan if they need to do anything, what they need to do? We do these special investigations at the cleft units around the UK. We do a lateral video fluoroscopy where we look on the side and have a look at the soft palate. Here it is in pink to see is it too long, is it too short, are the muscles in the wrong place? Or we might do a nasendoscopy where we put a nasal endoscope down the nose and view the velopharyngeal sphincter from above. Both of these procedures have to be done with the child awake and talking, so we can see dynamic movement of the sphincter. We can do videophoscopy from the age of about 2.5 with a really cooperative child that we've befriended. Nasal endoscopy a bit later, probably from about 4 to do that. And how do we manage? So if it's a cleft palate, it would be repaired in the UK, typically between 6 and 12 months of age, a cleft would be repaired. Submucous cleft palate, again, would be repaired if it's symptomatic pretty soon after we've spotted it. And then there are these secondary operations that can be done if the primary operations to do these repairs haven't been sort of successful. So speech therapy, a speech therapist needs to identify what sounds a child is struggling with, and then to either offer them a course of intervention, or I would liaise with the speech therapist in the locality where the child lives, whether that be Rochdale, Bolton, Bury here in the northwest. We decide on an intervention approach, and ideally for children with speech sound difficulties, they would be seen face-to-face for a direct therapy session with long blocks of speech therapy. It might be supported by speech therapy assistance. Unfortunately, in the UK, it tends to be a prescription of 6 weeks of therapy at a time, which really isn't enough. But that tends to be what's delivered. And this is key. I'm just going to go on about this a little bit. Family needs to support the therapy. A child will make a lot quicker progress if there is practice at home. So the Royal College of Speech and Language Therapists have published some data recently. There's 25% vacancy rates across the UK for paediatric speech therapy. So you might be living in an area where there isn't a lot of speech therapy, where you're seen by your child seen by your speech therapist once a term. So it is a real issue, and there's a petition at the moment, a national petition. There's 8,000 signatures, and I checked this morning. They need 10,000 signatures for Parliament to acknowledge the shortfall in speech therapy, and I think with 100,000 signatures for the lack of speech therapy to be debated in Parliament. So there is a real national shortage. So how can parents help? So link up everyone that's involved. It's bizarre that sometimes, you realise that, the parent hasn't told the teacher that the child's got a cleft palate and that they don't know the speech therapist is involved. So it's great if all the health professionals and the education professionals can be linked up so that we can all work together to support a child. I think we've already heard about working face-to-face, so children with cleft palate can have problems with their hearing. They also have problems making speech sounds, so if you sit opposite them, they can watch your lips to see you make t and th sounds. Practice, practice, practice. I'm going to talk a little bit in a second, very quickly, about dosage. Make speech work fun, set targets, and also incorporate speech therapy practice into daily routines. Children are busy, we're busy, but if you can just practice every time you're in the car, every time at a red traffic light, your child says their target sounds. Working with a 14-year-old at the moment, he doesn't see his mum very often because he's in his bedroom, but she does drive him to school every day for 20 minutes, so that's when they're going to do their speech practice. So it's about finding times in the day that you can use to do this speech work. Early intervention, so for littlies, there's lots more out there. So there's some books devised by 3 specialist speech therapists who work in the cleft field. Lovely, lovely books for inputting sounds to children. They rhyme, you repeat the sound in the stories. There's lots of things parents can be doing from early days to support the children. And I'm also going to give a big plug to this Tiny Happy People website. Don't know if anyone's heard of it, but it's a BBC website that's been put together to give ideas and videos to parents on children's development, particularly their speech and language, and it's absolutely brilliant. They're developing it all the time. It's a really, really worthwhile website to have a look at. There's also something else called My Mouse Music. It's devised by a speech therapist and a music therapist in Queensland, Australia. I have a speech therapist called Sarah Kilcoyne. She now works over here in the Oxford Craniofacial Unit. It's a really nice resource. So if you Google it online, all the words to the songs come up, and there's little QR codes for you to click on for music. And there's songs like Happy Bus for saying buh, buh, buh over and over. And there's Huff and Puff with Mr. Wolf. So they're lovely songs. You can sing them in the car with the children. I can give you more information on that if it'd be helpful. There's other techniques. I like this technique where I use hand signs to remind children how to make sounds. So I'd be doing puppy or baby or shh. So there's all different props and things we can use to support speech therapy and help children make quicker progress. And technology. There are now these lovely speech apps with super pictures on. It just makes it a little bit more fun for children. So we don't like children sat in front of tablets all the time. It's not good for speech and language development typically. But if you're sat with your child working on a specific sound, using this kind of app, then that's great. Dosage. I'm going to plug dosage. Speech therapy sessions are typically 20 minutes, 30 minutes. Speech therapists have been getting children to say target sounds about 30 times in a session. Latest research has said the child needs to be saying the target sound, the new sound, at least 70 times in a session for it to be effective. So as speech therapists, we're having to work harder to get the children to say the sounds repeatedly as we can, but also you can back that up at home with additional speech to practice at home. And we do lots of things where we've got a game where the child has to get 100 crosses in the box if they've said their sound 100 times in a therapy session. And children are really competitive. They like that. They want to achieve. So we're having to tweak a little bit what we're doing nationally to improve the dosage of speech therapy. This is again just to talk about how empowering parents to help more can improve speech outcome, can quicken the process. I think that's everything. The whistle stopped from me.